it? How did they do it? Did they do it the right way? What did they miss out? What questions should they have asked that they didn't ask? Some of these things could be, yeah, even local intelligence can help you to be able to question some of these things and understand them and appreciate them in practice. So let's say a study recommends combination therapy for, let's say for example, sepsis. So, and now you are looking at that study, and the question could be, was there any underlying difference between the study population and my population? So if this study was done in so and so patients that have this and have that, or are not taking this and not taking that, and it is brought to you as a new evidence, you could look at it and say, well, this is a new kind of evidence, but this population is different. So it is important to look at the population. And then the study may not have used any control group. And so if each time they don't use a control, the evidence looks bigger. It hyperbole. So you have to ask those questions. What was the control group? How did they select the control group? And all that kind of design question. So these questions can now help to determine is this study relevant or not. So we're going to be looking at a study, a randomized trial on antibiotics that was reported, and we're probably going to just look at the abstract, and then be able to use the CASP tool to ask the question, was the randomization proper? Were outcomes objectively measured? Could there have been bias in it? What was the dropout rate? Did they adjust for confounders? Did they even report them in the results? Or did they even acknowledge the possibility of those? So this approach will help to make some kind of informed decision. And we'll be looking at a case in a minute. But before then, how does critical appraisal strengthen antimicrobial stewardship? It helps us to develop treatment guidelines. It helps in the training of new prescribers, at whatever level, mid-level prescribers, MDs, whatever. The appraising, the critical appraisal will strengthen the stewardship, and then help to train the new set of people. In one of the series, I think it was either last week or the week before last, we said in Nigeria, for example, by 2050, our population has been projected to double. And so we are going to have a young population. By 2050, the median age of that population will probably be about 19.5 or 19.7 years old. About 70% or 75% of that population in Nigeria by 2050 will be less than 35 years old. And so we can see that there's already going to be epidemiological shift going by the demographic shift. So we'll have 450 to 500 million people with this median age and all the, so you can think about what is going to be happening, what issues they're going to be dealing with. Housing problem, having children and children's pediatric issues, and pregnancy related stuff, infections of all kinds, STDs and stuff like that. So, now knowing and understanding this shift would help in updating the curricula for the educational system for the next set of graduates that are going to be addressing these issues. People like us will probably be retiring by that time. But so if they are still using the curricula that they used to train us 25 years ago, they are left way behind. So critical appraisal will help to see where the evidence is going and to verify and re-verify the evidence within this space, and then use it to inform the training, use it to inform treatment guidelines, use it to inform curriculum updates, to also even help to choose the appropriate diagnostic tools that could be used, in real practice going forward. So without critical appraisal, we know that part of the problem is that antimicrobial stewardship will just become a guesswork. And the chances are that when we guess it wrong. And the problem with microorganisms is that the more you expose them to suboptimal doses of an agent that doesn't work, the more they develop resistance to it. And so in certain health systems, in the UK, given their own arrangement, you can't even write some prescriptions without calling maybe the microbiologist to say, hey, can I use Cipro? Or can I use Augment? Or can I use, you have to get approval to be able to write certain antibiotics, prescription for certain antibiotics. In Nigeria, people walk across the shelf and say, give me Cipro. Augmentin doesn't work for me. Give me that one. Over the counter. And so that is part of the reason why this is a big problem, and it's going to even be a much mega problem if we don't do something about it. Once we have appraised evidence, it's important for us to act in a way that reflects that our knowledge is updated. We must use local data. We must have a way to adapt our guidelines to reflect current evidence. And we can even begin to review our patient outcomes to see if they reflect the impact of those new evidence. And this is always the reason why data is important. Data is important. And in our system where people are still doing things manually, it's difficult to keep up, to keep data, and to be able to monitor trends and document. And then, of course, one of the things that also need to happen is that we need to update protocols. In Nigeria, a lot of people, a lot of hospitals, clinics, health systems practice without protocols. They practice without proper guidelines. They use the residual knowledge of what they remember from university days, many years post-graduation. And that in the West, where regulation is more proper, where the system is a little more organized, all these things, there are protocols, there are guidelines. And when I was working in the UK as a clinical auditor, most of my job was based on those guidelines and protocols to check that people comply with those protocols and guidelines. Because there is a reason for which they are designed. And there are people whose job it is to make sure that they are updated and they're reviewed periodically. So, and the process of reviewing this and updating it is important aspect of continuous quality improvement. And continuous quality improvement is part of the requirements of our profession as custodians of public health. So it is important that after we appraise resistance data, for example, that we should be able to review, see how that affects what we are doing in the whole system, and if need be, a steering committee could be put together to review. So I don't know if anybody has any questions so far, or otherwise I would go on to look at the case of the abstract that I wanted us to look at, and then I will give us throw the floor open for people to start making some contributions. Any questions so far? Okay, so let's consider these questions, and then we look at a case. What type of study is this? So remember this question. What type of study is this? Is the research question clearly defined? Are the results valid and applicable? What are the strengths and the limitations of the study? Again, I want you to remember, I'm going to read the abstract in a minute, but then remember, what type of study is this? Is the research question clearly defined? Are the results valid and applicable? What are the strengths and the limitations? And this study shows, the title of the study was Reducing Duration of Antibiotic Use in Community-Acquired Pneumonia, a randomized control trial. So once you read that, it already tells you what they are trying to do. Prolonged use of antibiotics continues to antimicrobial resistance or contributes to it. This study evaluates whether a 5-day antibiotic regimen is as effective as a 10-day course for adults with community-acquired pneumonia, CAP. A multi-center double-blinded RCT was conducted in 5 hospitals. 300 adult patients with diagnosed CAP were randomly assigned to receive either 5 or 10 days of levofloxacin. Primary outcome was clinical improvement at day 15. Secondary outcomes included relapse rates and adverse effects. Result: clinical improvement at day 15 was observed in 90% of the 5-day group and 88% of the 10-day group. The p-value is 0.67. There were no significant difference in relapse or side effects. The study concludes a 5-day course of antibiotics is non-inferior to 10-day treatment in uncomplicated CAP, supporting shorter regimen in antimicrobial stewardship programs. So, our questions, I asked us the question to remember the question. What type of study is this? Is the research question clearly defined? Are the results valid and applicable? What are the strengths and limitations of this study? So let's answer some of those questions, and then I will let us reflect. So, number one, what type of study is this? Our study is a randomized control trial, and it was actually a multi-center, double-blinded, randomized control trial. So we know that RCTs are considered the gold standards for evaluating the effectiveness of interventions, because they're supposed to minimize bias by the process of randomization and blinding. So we could say, so it was an RCT. Is up there, maybe next to systematic reviews and meta-analysis, just around there. So, is the research question clearly defined? I would think yes. It was stated clearly, because he said it's about, does 5-day antibiotic regimen, in this case was levofloxacin, produced similar clinical outcomes as a 10-day regimen in adults with community-acquired pneumonia. So far we can say yes. We'll come back to it in a minute. Now, the aim is very much focused, is very relevant, and it addresses a very what I would call a very clinical and public health issue, significant as it is, antibiotic duration. In the context of antimicrobial resistance, yes. So it's trying to figure out whether there's any significant difference between a 10-day and a 5-day duration for uncomplicated community-acquired pneumonia. Now, are the results valid and applicable? Valid and applicable. So we can look at validity at one level and applicability on the other hand. On the hand of validity, we could be looking at the study design. It's a double-blinded RCT. So, is it appropriate for the question? I would say yes. So now you see, I'm engaging with that evidence. Randomization and blinding was done, and these ones are supposed to reduce bias at different levels. So, okay, it talks about the sample size. There are different ways to determine sample size, but looking at this study, 300 participants look like, for me, a decent sample size to be able to determine difference in the moderate differences in between the two arms. Now, the outcomes, were they objectively measured? Yes. Clinical improvement, relapse, adverse effects were reported here. So, and we see the p-value was reported, 0.67. So, which suggests no significant difference in the primary outcome, supporting non-inferiority. Now, the non-inferiority is very important, and it implies that a formal non-inferiority margin was kind of predetermined. Although in this our study is not explicitly suggested or stated in the abstract. So the abstract didn't explicitly say that, but we can see that it seems to have been suggested. Now, the applicability. So I said we look at it from two different sides, the validity and the applicability. This intervention, which is a shorter duration, is practical. And it can also influence a clinical guideline, especially with developing strategies for antimicrobial stewardship. Now, the study population itself, of course, remember it was adults with uncomplicated CAP. So this is a common situation in real world. So can we then generalize the result of this study in comparable populations? Probably yes, probably. To a great extent, I would tend towards yes. Now, the use of levofloxacin, which is a commonly prescribed antibiotic, increases external validity, because this is pretty much used well in real life. So, but if you look at that abstract again from critical appraisal perspective, it does not really specify inclusion and exclusion criteria. So because he did not do that, he reduces applicability. It may vary from patients, for patients especially who have other comorbidities. or who have other more serious illnesses, or who don't very much fit into this mode that fits the people that they used. Now, what are the strengths and the limitations of the study? Very important. So, we already said that the study design was robust enough, multi-center, double-blinded, randomized control trial. So, internal validity is high. Is the topic relevant and timely? Yes. It addresses antimicrobial resistance. So, it couldn't be any more timely. Otherwise, we won't be talking about it. The outcomes, very clear. Clinical improvement, relapse, side effects, these are all relevant. And it was all patient-centered, very objective outcomes. Now, direct clinical application. This result can inform changes in prescribing habits, at least for that people that fall within that population that was studied. But it has some limitations also. And so, at the end of it, we have to weigh the strength versus the limitations to make the clinical decision. At the abstract level, we see that the key methodological details, example, it says randomize, but how did they randomize? We don't know. We don't know what the adherence rate was, what percentage were lost to follow up. Are there some missing values? If there were missing values, how did they account for for missingness? We don't see any of that. So that becomes an issue to contend with and to factor into the decision of applicability. There was no mention of severity scores. There was no mention of certification in the process. And this is important. So the treatment outcome, because of this lack of disclosure of the severity scores or something, might question the applicability of this stuff. Now, the follow-up was captured, the outcome measure was captured at day 15. So, what about day 20? What will happen at day 30? If day 25? So, we don't know what could happen in a longer time follow-up. So again, the study only picked day 15. What informed day 15? Maybe what if they carried out a study that shows day 10, day 15, day 20, day 25? Would there be difference? Significant difference between them? We don't know. So this become like some kind of limitation of the study. So I think that follow-up may be short for this kind of situation, in my opinion. Now, it was just a single antibiotic regimen, which is fine, but how about other antibiotics? What about people who use multiple polypharmacy? So for the broader patient population, how applicable would this be? People who have atypical pneumonia or other comorbidities, how does it apply? So you see that the applicability, adaptability of this will have to be balanced from some of these questions. Now, when you talk about non-inferiority, was not really properly defined. So while we can claim it because our p-value shows 0.67, our confidence intervals were not presented in the abstract. So sometimes we need to see all of those pictures to be able to have a proper understanding of what is going on with the data to be able to interpret them properly and make sure that they are not just spurious conclusions and findings. Anyway, so what I have tried to do is to interrogate the evidence just based on an abstract. So we may have to look at the full study or the full paper to be able to reach a decision that will be evidence-based, that will be applicable, that we can defend at any time. So, but by and large, this study kind of presents what we would ordinarily call a high-quality evidence, suggesting that 5 days antibiotic course is as effective as a 10-day in uncomplicated CAPs. So, and that would reinforce the idea that shorter is not worse than longer in certain of these kind of situations, given antimicrobial stewardship. So while the design is strong, RCT is strong, it's supposed to be able, is strong enough, is strong that it can establish causation. It can really tell us, yes, this is it. The question is also relevant, but full appraisal is needed to be able to answer some of the questions that we raised that were not really properly reflected on the abstract. And sometimes abstracts are limiting because they limit you on the number of words, and so some people don't know how to use words enough to be able to compress as much information within that box. But be it as it may, we have to engage with the full paper to be able to access the full extent of the methodological rigor that went into this study. If there was any subgroup analysis that happened with it, we'll be able to see. And then we can then assess the robustness of the non-inferiority claim that we are trying to make. So, anyways, I hope that puts in perspective what I was talking about, the place of critical appraisal in antimicrobial stewardship. So, I'm beginning to round up so that I can throw the floor open. Common pitfalls in antimicrobial resistant data use. Sometimes it has been documented that there could be misinterpretation. So people can tend to misinterpret causation for association. They are two different things, and the designs are different. And sometimes people may even find association, but misinterpret the strength of the association. There are ways to establish those. Now, oftentimes in this part of the world, we tend to rely on what we call global guidelines. Global guidelines can be good, but sometimes when you put them in the light of local realities, they don't stand. So there is always a need for the local validation of what we could call global guidelines, so that we can tailor it in a way that makes sense within our space. That's why we are promoting the critical appraisal skills. Now when we ignore publication bias, then we could run into some issues. And sometimes there is a lot of publication bias. Sometimes the difference could be in who paid for this study. What was the interest of the person that actually paid for this study? It could be who carried out this study. And in some places, people are in a hurry to publish or perish. So sometimes some of the so-called data could be manufactured on the desk, So these are some of the things that we have to, bring into perspective. So, how do we apply some of these things in um, especially the global guidelines in our local realities, and how will appraisal help us to be able to judge transferability of evidence or transferability of appraisals in our own situation. This will be one of the things. This will be some of the issues that I would want us to think about as we go from here. So, my question to us tonight will be, what would be one thing that you would want to do differently as far as antimicrobial stewardship is concerned from tomorrow morning? Maybe it's just to review a study more carefully before implementing, a protocol. You could be questioning more about what did they not do versus what did they do, or who was left out, who counted and how did they count, and was there any bias, from the beginning or implied in the study, or asking for sometimes if you begin to ask for the original evidence, in that detail you could find the devil. Sometimes some guidelines based on the local peculiarities, not just on the raw evidence from scientifically unbiased executed study. So we must be mindful of those kind of issues, because sometimes small issues like those can lead to very huge impacts. And a lot of I think it was about 3 weeks ago we talked about how a lot of our policies are based on unquestioned, unchallenged evidence that were never put through the rigors of critical appraisal. Because and we gave examples of some of our policies when we're looking at the critical role of critical appraisal in governance, in policy, in public policy, and in regulation. So if you see that thing, it will be good to listen to it. I recommend. So now I want to hear from us. What challenges do we face in applying evidence in our settings? What appraisal tools have you used? Can we share your experience? So the floor is open. Anybody can speak. Thank you very much. Is Dr. C on the call? Is Dr. Chema still on the call? Topic: antimicrobial resistance. What experience do you have in the communities? Or what challenges have you noticed? All right. So in the absence of questions, again, thank you for joining the call. Next week, what are we talking about next week? I think we are looking at pharmacovigilance. Is that? Yeah, I think we'll be looking at pharmacovigilance next. So I believe so. The critical appraisal in pharmacovigilance. I think that's our next topic. But I will see. So by this time next week, Monday, we'll be on call again, and it will be our honor to have you. Otherwise, if you have any questions or any issues, or wish to know how we can help you to apply some of these things in practice, please do well to reach out to the Right Place Institute for Leadership and Strategy. My name is Chukwumezie Okolo. Thank you for calling in and have a wonderful day.